Hello, everyone, and thank you for joining us for this roundtable discussion on healthcare policy topics that patients should know about in 2023. Whether it's at the state level or federally, we will see potentially good and potentially harmful legislation affecting patients all over. Today, we will be highlighting 3 issues we think you should know about going into the 2023 legislative sessions. I'm joined by 3 experts who will introduce themselves now before we get into the discussion. Lou, would you like to start us off?
Sure. I'm Louis Tharp. I'm the executive director and co-founder of the Global Healthy Living Foundation.
Robert Popovian. I am Chief Science Policy Officer at the Global Healthy Living Foundation. I'm also a Senior Health Policy Fellow at the Progressive Policy Institute and a Visiting Health Policy Fellow at the Pioneer Institute.
Hey everyone, my name is Terry Wilcox. I am the co-founder and CEO of Patients Rising and Patients Rising Now.
Great. As you can see, we have a great cast of experts joining us today. So without much further ado, let's get right into it. First, let's dig into PBMs, or pharmacy benefits managers. I think to get us started, we should probably define what a PBM is and does. Robert, could you take this question?
Sure, happy to. PBM stands for Pharmacy Benefit Management, or managers or management companies. These entities exist to be able to manage pharmacy benefits for employers, the state and federal government, and other entities. They came into fruition in the mid to late 70s, and they've been around for a very long time. The original purpose of PBMs was to process prescriptions through your pharmacy. So it made life easier for pharmacists and pharmacies. When patients walked in and they were using their insurance card, PBMs were there to process those prescriptions and to pay pharmacies for the dispensing of the medicine and collect any kind of out-of-pocket costs that the patients may have. However, since then, they've ventured into areas that really have been problematic for both patients, federal and state government, and employers, where they have begun to manage benefits of pharmacy, specifically related that they're developing formularies, they're involved in formulary exclusions, they're doing contracting with pharma companies and collecting multi-billion dollars in rebates and fees that nobody knows about, or it's very opaque and we don't know how much of it gets passed back to the government or employers. And finally, the most recent ventures have been purchasing of specialty pharmacies. PBMs own about 80% of that market, so they not only control development, processing of prescriptions, but developing formularies and benefit design, but also now dispensing of medicines, the specialty medicines especially, where all the rebate contracting and the multi-billion-dollar concessions take place. And finally, they are also now vertically integrated with insurers, which makes it even more opaque about how they can hide money, because in the past, there used to be an entity that the insurance companies would work with. Now they own those insurance companies, so they can hide even more money in those supply chain environments. So there's some benefits to having PBMs, but most of the practices that they have are problematic, and they create a lot of misaligned incentives in the market and access issues for patients.
Great, thank you so much for that response, Robert. And I know you touched on this a little bit in what you just said, but Terry, could you tell us more about how PBMs explicitly harm patients?
Well, one of the ways they explicitly harm patients is just through the sheer, when, as Robert mentioned, they've been taking over the benefit design. And as I always like to say, the number one access issue for patients that we talk to on our Patients Rising Concierge hotline, well, the number one and number two are actually transportation and caregiving. But when you get to number three, I call it benefit design. And it's every single other thing and reason why you cannot get a treatment or a medication or whatever. They have designed it in such a way, they've created tiers that either put it out of reach, or it's not on the formulary, or if it, or they put it on a tier where your co-insurance for it is, 40% or some insane amount of money, or they've also had a huge movement to high deductible health plans, where you have to meet exorbitant out-of-pocket costs before you can get there. step edits, I mean, other things that we're going to talk about today, and ways that, they affect patients being able to get immediate access to what has been prescribed by their doctor, whether it be a medication or some kind of procedure. So.
Thank you. So why have PBMs become so powerful? Feel free to answer this.
Well, to be honest, the reason they've become so powerful is because we've had a federal government that has not paid much attention to what they've been doing, and they've been very laissez-faire about the activities that they've engaged in. Traditionally, the thought was that they are good stakeholders that are managing drug benefits for patients. And the other thing is that the federal government and the state government and a lot of employers actually look at them in the wrong way. They look at PBMs and insurers as payers. The true payers in the market in the healthcare are patients who open up their wallets to pay for everything. And you can argue probably employers to a certain effect. Even the federal and state government are not real payers because they tax us for payment of healthcare provision in this country. So I think a lot of reasons is because there was a lot of trust and not verified trust by the federal and state governments that they've handed over this business to them, and they've taken advantage of it. And now they're realizing through the work that's been done over the last maybe 6 years or so, half a dozen years, that there's a lot of problems that exist that they need to now go back and try to unravel some of the mess that they frankly created by being very hands off.
Okay, so where do we go from here? How do you think we can legislatively combat the harmful practices done by PBMs? Lou, do you want to take this question?
Traditionally, in commerce, companies have to earn your business. They have to provide you with what you want and what you need at a reasonable price in order to be successful in the market. PBMs have turned this upside down. And as Robert said, the government's been sleeping for the last decade and a half. And so what we need to look at are ways to create the incentive for patients to be able to say, yes, I want this. No, I don't want this. And right now they can't. They're saddled with a PBM. They have no option for picking a PBM that might be better for them. They get a PBM that comes with their insurance. And so what happens is that from the moment you call and you get lost in their 10-minute phone tree to talking to a customer service rep, you are faced with a Hobson's choice, which means you have no choice. They're surly, they're aggressive, they're dominant. They know you have no choice but to accept whatever it is they're going to say. And if you compare this to Medicare, if you call Medicare, and I've called both, you get a sympathetic, empathetic voice on the other end of the line with Medicare. You don't wait as long as people would have you believe you wait. I've waited much, much longer to talk to a PBM than I have to talk to Medicare. And the unfortunate part, though, is that Medicare has farmed out the drug distribution to PBMs. So I'm fine calling Medicare, but then I have to call Cigna because they have my Part D. And so you run into the same situation. So until legislators can understand that they need to create an environment where PBMs earn your business, and if they don't earn your business, you don't give it to them, and they're fined or they have to give you money back, we're not going to be able to move forward.
Would anyone else like to tackle the question of how do we fix this? Is there anything that's been successful legislatively to regulate PBMs at the state or federal level?
I want to add one piece to that. So the FTC is currently investigating PBMs, and Lena Khan, who is the head of the FTC, who incidentally, Erik, is an associate law professor at Columbia. She has created an environment where if anything's going to get done, it will get done here. And we hope that she can get to the bottom of this, and we hope that she can. She has enough power to create that set of regulations, or that set of suggested regulations and laws for Congress and also for state legislatures to adopt. And in the meantime, make it painful for PBMs. PBMs have paid 300, give me one moment here. They have paid $370 million in fines as of 2019, when they were sued by attorneys general in 20 states. So that's a rounding error to them, number one. But number two, we know it was just enough to make them angry, because they doubled down on their policies and they're fighting the FTC. So the FTC has to pick up where the attorneys general left off, and they have to put together a package that brings PBMs to heel, that allows the consumer to have more power. And this could be any kind of legislation that demands certain milestones, certain deliverables to customers, patients, that allows for more transparency, and that allows for patients to negotiate the services that a PBM offers. Patients shouldn't have to take all the services PBMs offer. They should have a choice. They should say, no, we don't want that. We should also be able to choose our own PBM.
So from practical purposes, what FTC is doing is great, and they're going to investigate it. And I'm hoping that they will be able to come up with some type of solutions, both on the state and federal level. But meanwhile, I think what we're doing is that we have to create an environment that, number one, you break up these monopolies, right? So we talked about 80% or over 80% of prescriptions processed in the United States are managed through three largest PBMs in this country, which is Optum, CVS Health, and ESI. So that's one problem right there, that three entities control 80% of the market. Number two is that 80% of the specialty drug distribution through specialty pharmacies are through PBM-owned pharmacies. That's a problem, because now they're controlling distribution. So both of those need to be addressed. But before we address any of this stuff, we need better transparency and audit rights, but by individuals, whether it's the government or employers. They need to have the ability to audit these PBMs. They're very good about hiding money, and they've found many ways to hide money. So what we need is an all-encompassing ability for somebody to create a transparent environment that every dollar that they collect, whether it's in the form of a fee, a form of a rebate, a concession, a discount that comes to them from the biopharmaceutical industry, is accounted for, and exactly we know where it goes. And not fees that are done through the rebate contracting model, but also fees that they collect for specialty pharmacy distribution and so on. In addition, we need to find out how much are they overcharging patients through the spread pricing issue, which we know it's multi-million dollars that takes effect. And that's only in the generic market primarily. So those are the things that we can create, Erik, is that create an environment which is very transparent for us to be able to see where the money flow is going, and then have audit rights for individuals who bring these companies in to manage pharmacy benefits, to have the ability to audit them without any kind of concerns. Right now, the federal government has zero audit rights over the PBM businesses that they have farmed out, like Lou said, the Medicare Part D program. Most employers, even the self-insured ones that you assume have a lot of power that they can get audit rights, don't have those rights, or they're rebuffed, or they're given a lot of the runaround. So what we need to do is create an environment that we have full transparency about how the money flows within these organizations, and not just the contracting part or the pharmacy benefit part, but also the medical benefit that a lot of drugs are being paid for, and also the specialty pharmacy business with the distribution that takes place.
And I can add a bit to what Robert said. You know, most people in the United States don't deal with PBMs on a regular basis. The people with chronic disease, the people who need the specialty pharmacy do. Because of that, it can be very difficult to pass meaningful legislation because if it's not happening to you, you tend not to worry about it and you tend not to make it a priority. And if the majority of people in the United States don't make it a priority, then the politicians are going to listen to that and they're going to move toward issues that the majority of people care about. The problem with that is that just like life insurance, you're going to use your health insurance. It's just a matter of time. And so when you do, then you become one of those people who gets angry and frustrated. And the issue we have in the United States is that it's a revolving door of people going through, and we don't get to critical mass when it comes to legislative priorities because we're dispersed. So the PBMs can get away with this kind of abuse year after year because we don't make a loud enough noise. The same was true with climate change. People didn't recognize climate change as an issue. Now people do. And now we've had the most significant legislation in the history of the US passed this year to combat climate change. I'm hoping that we can get to that point. The experts already say that we have the worst healthcare system in the world for everybody. It's a great healthcare system for rich people, but for everybody, it's the worst of any industrialized country in the world. And so we need to be able to create that unified voice and then amplify it so that these PBMs especially get the message and they understand that they can't continue what they've been doing for the last decade and a half.
Great. I hate to cut off the conversation here, but I want to move on to our second topic. So something we hear a lot about as a patient advocacy organization is step therapy or fail first policies. So let's discuss this practice. Terry, do you want to get us started with this one?
Sure. Step therapy, for those of you who don't know about step therapy, that's when you go to the doctor and, well, I'm going to use rheumatology and immunology, as an example, because basically any rheumatologist that you talk to in the United States, they'll tell you, I don't decide what the best treatment is for the patient first. I have to look at their insurance because there's, what's covered, what's not covered. And sometimes even that's not enough. And so say you do get the special patient or a patient where you're like, okay, this patient must be on this. And then they'll look at the formulary and they'll be like, okay, well, they have to try this, this, and this before they can get to that. So it's basically saying that you have to go through a series of steps that are probably not necessary and may actually make you worse or not work to get to the treatment that your doctor wants you to have. This is very common in the psoriasis, multiple sclerosis, rheumatology space. It's very common. And there's a lot of legislation that's been passed around the country. I'm going to let Lou speak a little bit to this because I think Global Health Living did some great research around the state legislative, the state legislative actions and what they actually did and didn't do. But that's basically what it is. It's a patient having to go through and take and also another thing that happens in the United States many times, and we're actually I'm working with a few patients that are going through this right now. They've changed insurance, and it's not like the new insurance will see that the patient's already been through the process with another insurance company or another plan or something started over. So sometimes they have to do what they've already done and what's documented, what is actually documented that didn't work again, or at least go through hoops. So I hope I didn't make that too complicated, but that's the basic gist of it for many patients.
Yeah. Let me follow up on what Terry said. So right now, Ohio has the strongest step therapy law in the country. There are 29 states at last count that have step therapy laws. That means laws that prevent, to some degree, in one way or another, PBMs from keeping you away from the drug that your physician required. So there are two two points I want to talk about. One of the laws themselves, and another is the price. Let me start with the price. PBMs are famous for saying we save you money, that step therapy saves money. Really what step therapy does is add to their profits. It saves them money. And regardless of whether your step therapy, whether you're asked to fail first on a generic drug or a branded drug, when you do that, what you're doing is feeding the PBM's bottom line, because they start you on the drug that is most profitable for them. And then they move you up if you can yell out enough and if your doctor is persuasive enough to the drug that your doctor actually prescribed. So the pricing issue is really important here, because we look at drug pricing as the price the patient pays. Well, that might be with copays. That could be because you have a great health plan from your employer. It could be in a whole lot of different things. But the step therapy cuts through the middle of all of that, regardless of the price you're paying, and makes you fail on a drug that your doctor prescribed. So if you don't want to participate in step therapy, again, they don't earn your business. They say, fine, you can take the drug your doctor prescribed. It'll cost you, now pick a 4-digit number per month, because that's usually what it comes out to. 2,000, 3,000, doesn't matter. So now let me talk about the laws. We worked very hard to get these laws passed in 29 states, along with many other nonprofits and for-profit companies that understood. And those included employers and other companies that have an interest in a fair healthcare system. But what happens is we wind up in two situations. First, the patients in a state like Ohio may not even know that law exists, because the insurance companies aren't going to tell you. The PBMs aren't going to tell you. Your doctor may not even know. And it's up to you to understand the law and then aggressively apply that law to the PBM. And that's an uphill battle. And remember, you're sick. So do you really want to do that? It's tough to do that when you're sick. So the other part of the laws is that a lot of them have no teeth anyway. A lot of them have no penalties if the PBM violates the law. The actual law doesn't cover many of the practices that PBMs use against patients. And so we have a system in the United States, first of all, that should be covered by federal law. Second of all, is covered by state law that patients may not know about and that may have no teeth. Now, the third problem with the laws are they don't cover the majority of people, because the majority of people are covered under ERISA controlled insurance policies or insurance programs, and the state laws have no power over ERISA controlled health plans. So the largest companies in the United States, their employees are not covered by these state laws. So we've tried, and it's an uphill battle. Remember, the main movers of the anti-step therapy laws have been nonprofits. The main defenders of the step therapy laws have been PBMs and insurance companies that make hundreds of billions of dollars a year. So it's a very difficult task we have in front of us. And the results show that we don't have the power we need in order to affect change. And it goes back to the fact that the politicians are not necessarily motivated to do this if they're not hearing from their constituents. Or if you're in a state like Missouri, where Express Scripts happens to be domiciled, you're hearing from the lobbyists from Express Scripts, and they're saying, we employ X number of people in the state of Missouri. Do you really want to fool around with this? And the state legislatures generally say no.
So as a healthcare professional, and this is where I put my hat on, I can tell you the biggest problem HCPs have with step therapy is that the insurance company or the PBM that institutes these type of policies never bring up, what does failure mean, right? Is it hospitalization? Is it mortality? And from a legal standpoint, all of that is passed on to the healthcare professional to be liable for the poor outcomes, and they take on none of the liability. And that's been the issue with most healthcare professionals. So not only they're intervening into the practice of pharmacy and practice of medicine, but they're also taking on absolutely zero liability for the decisions that they're forcing these healthcare professionals to make, which is against the better judgment of their profession. So that's one of the issues that HCPs have, and Lou's absolutely right. I mean, it's not just step therapy, but one of the mechanisms that these institutions are able to sort of work step therapy into the system is called prior authorization, which you may have heard about. It's something that you have to get prior authorized prior to having a therapy approved for you as a patient. Well, not to be self-promoting, but GHLF did a study specific looking at prior authorization. Last year we published it in a peer-reviewed journal, and what Lou said is absolutely true. The claim that the PBMs make that it saves money, things like step therapy and prior authorization in this case that we looked at, is absolutely true. It saves money for the PBMs and the insurers. But the people who are burdened with the cost are employers, patients, and healthcare professionals who have to go through these things. So the net cost to the system is significant whenever you do these things. The savings only goes to the entity that is basically making everybody else jump through the hoops. And the three entities that are hurt the most are the patients, employers, and the healthcare professionals who have to be burdened by this type of policies.
Now, in 2019, we did what I think in the industry, without sounding too much like we're bragging, this seminal study on step therapy, and it was published in the peer-reviewed publication, Health Economics, Policy, and Law. And it spelled out what the state of play was at the time it got published, which I believe was third or fourth quarter 2020. And what Robert was saying and what we're talking about here today was pretty clearly defined within that paper. And the result, though, is that one published paper in a respected peer-reviewed publication about step therapy, and then another one about prior authorization, are baby steps. And we're taking them. You have to continue to try, and you have to continue to take these. But we also have to be realistic. We have to understand that the PBMs have a hundreds of billions of dollars in profits to protect, and nobody is going to give that up easily. And so the patients are the ones who are going to pay both from their wallet and with their health, as long as prior auth and step therapy are in place. Now, there is a legitimate reason to have prior authorization, and there is an even more legitimate reason to have step therapy. The problem is that these have been bastardized by the PBMs. So if you have a chronic disease, you definitely want to step through a series of drugs. If you're being treated for any number of cancers, you want to step through the drugs that begin to have the least side effects, that are proven to be most effective in a large group, a large population. If then those drugs don't work, you should be able to move forward with other drugs. That's a legitimate use of step therapy. The issue we have in the United States that doesn't exist in other countries in the Western world is that profit is inserted into the decision-making process. If you're in the EU, if you're in Australia, if you're in Canada, if you're in many Asian countries, price doesn't enter into the decision-making process. So you start out with the first drug. And interestingly enough, physicians already know this. Physicians are more than willing to step you through the correct drugs. The problem is, in the United States, they have to put up with the profit motives of the PBMs, who have a different idea altogether and who have never seen you. They're not your doctor.
Right, and
Well,
that's what I was saying. A lot of times the doctors have to look, to your point, Lou, they have to look at what the protocol is from the insurance plan, what they want to, what they would say, let's start here, as opposed to what the doctor would say, let's start here,
Really,
to jump through, you know.
absolutely great point. We know doctors who say, I want to know the patient's insurance before I even meet with them, because I'm going to save them a lot of heartache and I'm going to save me a lot of time. And how does that result in the best healthcare possible?
well,
You're absolutely right, Terry.
I think the only thing I will add is that when you look at things like step therapy or prior authorization, one of the things that we haven't done in this country is to really get the employers engaged on how much are they paying for these things. And I think, groups like Patient Rising and Global Healthy Living Foundation, that's what we need to do a better job of getting them engaged. Because at the end of the day, I don't know if people realize, but for every prior authorization that is done through a PBM for a patient, an employer gets charged as well, a fee. And that fee is up to the $150, $200 range. So they're more than happy to put drugs on prior authorization because they can make money not only contracting with pharma companies, but also make money by processing prior authorizations and charge that from the employers. So employers play a large role here and have been absent from the discussion. And I think the patient organizations need to do a better job of explaining, because at the end of the day, and patient organizations are not only patient organizations that represent patients, but also their employers that provide benefits for patients. And they need to be more cognizant and be able to have a voice in this discussion.
Okay, I'm going to pause the discussion here on this topic. So I'm sorry, I know that 15 minutes is nowhere near enough time to get into all the details of these, but I want to move on to our third and final topic for today. This one's a little more niche. Let's talk about a government program called the 340B program. From what I know, it has a lot of potential, but it could also be being abused. So, Robert, do you want to tell us a little bit more about the program and its problems, and then we'll jump into the solutions?
It's absolutely a valuable program that we need to think about how to preserve and stop having it being bastardized by for-profit institutions or pharmacies and also entities that are taking advantage of it. The program was set up to help hospitals, institutions that take care of clinics, that take care of uninsured, underinsured, indigent patients. I did my training in an institution such as that, LA County USC, when I was there in training in the early 90s. 99.9% of the patients were uninsured. And this institution really needed the help to be able to get cheaper drugs from pharma companies to be able to then subsidize and help patients who were not insured. They were not being paid for these patients that walked in through the clinic or the hospital, and they couldn't charge them because they were indigent patients. These patients had no means of paying for it. So it's an absolutely valuable program over time. Because of, again, the federal government not paying attention and also changing regulations. And one of the seminal moments where the regulation change was during the Affordable Care Act, where they opened up for-profit pharmacies to expand and become contract pharmacies with these institutions. And the eligibility criteria was never adjusted. There's there's HRSA, which is the agency within the government that oversees this, has done a poor job of regulating it. And now what we've seen is an exponential growth of not only covered entities, these institutions and clinics that qualify for this, but even a bigger expansion on the contract pharmacy side. And all of these contract pharmacies, about 80% of them are for-profit institutions such as Walgreens, CVS, Walmart, that engage in these things. And they become eligible because they serve a certain percentage of patients who are Medicaid patients, and automatically then they can get this money. And when they take this money as profit, what happens is that they buy it at much cheaper prices, and then they sell these drugs to patients who have regular insurance or Medicare insurance, which pay far more, and it's a profit-making machine for them, and that's where the spread happens. And unfortunately, The other thing that we've seen is that these for-profit, these covered entities, so become eligible, like these clinics or hospitals. And the New York Times had a great article about this, a hospital system in Richmond, Virginia, which basically expanded the 340B program, utilized the 340B program eligibility to get these huge discounts. And then they removed services from where the poor parts of the state that they were working on, and then expanded services in the richer part of the state of Virginia. So a lot of oversight is needed for this program because it is being abused by for-profit entities. And even if they're not for-profit entities, what we're seeing is that the underserved communities are not getting the benefit, full benefit of better services in their communities because of this program expansion.
Yeah, absolutely. To your point, Robert, that Bon Secours, that article that you just referenced, what they took out of that poor hospital, that hospital was just a glorified stand-up walk-in clinic. It didn't even have an ICU by the time they got done, ripping it of all the things that made it a hospital.
Okay.
It was really, and I actually came in contact. It's interesting to talk about, these covered entities and these other pharmacies, because I wrote a LinkedIn piece about, I published something on LinkedIn specifically around that article. And I had a couple of folks from the, the health community clinics that really need 340B. It's why 340B was created, right? It's for these, clinics with, they have AIDS patients and hemophilia patients and all sorts of patients that really need the program, and they use every dollar to help stand up that healthcare. And we had a conversation, and he said, Terry, I agree with everything you say, but you've got to understand, we really need this program to work. And now, because of all the abuse that the contract pharmacies have done, we don't have money in our clinic for a pharmacy of our own. And so we need some of these contract pharmacies to be able to get our patients their medications. And now we're only allowed to have one. Or with certain pharma companies now, we can't have any. There's no contract pharmacies, like they've totally pulled out of that. And so I'm just curious now, and they've put forth legislation, I know federally, I don't know if it's gone anywhere. I haven't even actually really had too much to read it, but 340C. And I'm like, oh, let's not start another program. Let's fix this one. Like, is there a way that we can, is there a way? I mean, there must be. I feel like to really fix it and to make it more streamlined so that the folks like this guy in Milwaukee who we had a conversation with, who really needs the program to work to serve his patients, can get access to what he deserves, because that's who the program was created for.
I serve on the board of AIDS United, and there are constituents of AIDS United who run 340B clinics, and they're smaller clinics, and they really do need the money from 340B. And it's a prime example of, the old saying, this is why we can't have nice things, because a group of companies have twisted 340B to their own benefit. And as Robert said, they're charging insurance companies the full amount for patients that could easily afford and aren't needy patients at all. And it goes back again to what Robert said. It's all about enforcement. If we're not going to have a universally accepted ethics philosophy around 340B, then we have to have strong enforcement. It's just like with the IRS. If we don't all think we should pay our taxes, then we have to have strong enforcement. And I'm afraid that's not going to happen anytime soon. And so what we see are pharmaceutical companies saying, you know what, I'm going to take my basketball, I'm gone. We're not going to play this game anymore. And I get it. And then the patients get hurt, and certain clinics get hurt, but the big hospital systems don't get hurt. And so it's a very frustrating period that we're in with serving patients who need care the most. And we have to have the adults in the room to sit down, and people ultimately are going to have to give up profit. And that's where it begins, and that's where it has to end.
So, I mean, GHLF is going to have a position on this, Lou, and I want to hear your feedback on this, and Terry as well, because there's 4 things that we're recommending in our recommendation on how to fix the 340B program, and Erik has worked on it with me. And this is important because number one, should institutions or especially contract pharmacies just become eligible by a certain percentage of Medicaid patients that they serve, or should the benefit follow the patient instead of the institution? That means the patient who's eligible walks into the pharmacy based on their eligibility should qualify, not the pharmacy itself as a contract institution or even the covered entity. So that's the number one thing is should the benefit follow the institution as it does right now, or should it follow the patient? Which we know in that case, it will make it streamlined and only the people who really deserve it will get that benefit of monetary benefit. The second part is whether or not, where are the locations of these contract pharmacies? So there was a JAMA article that came out early this year that showed most contract pharmacies are not located in indigent neighborhoods. In fact, they're in very expensive, very high zip codes, high income zip codes. So should these contract pharmacies be located where Terry was talking about, where these patients are actually going to, rather than all over the map, and including why are there contract pharmacies all over the country? For example, an institution like UCLA has 300 plus, actually, give you an exact number of contract pharmacies. About 20–30% of those contract pharmacies are outside the state of California. They're supposedly serving patients who are poor, that are affiliated with UCLA. But in reality is that if these patients are indigent, they're not traveling all over the country to go to these pharmacies. So why is it that they are all over the map, including pharmacies in Maine and Puerto Rico and Texas and Florida, when they're supposed to be serving people in Southern California? The third thing is, should there be charity requirements? That means if a covered entity becomes eligible or a contract pharmacy becomes eligible, should there be charity requirements that they provide? Right now, there is no requirement for charity care. Some institutions, Lou, you mentioned, they do a fantastic job. They put a lot of money back into the community and do a lot of charity care. Others don't. So should there be a threshold about charity, how much charity care each institution should provide, including the contract pharmacies? As soon as you put that on contract pharmacies, you're going to see a lot of them drop out because they just don't do charity care. And then the fourth thing is, should there be mandates or requirements for a threshold about these covered entities when they get this eligibility to put money back into the community, just like the Virginia hospital? Should they have made sure that there should be some reinvestment into these institutions that serve those communities, those poor communities? So those are the 4 areas that we're going to recommend. And I think it's pretty reasonable for people to look at it. And Lou and Terry, just to get your opinions about it.
So I love metaphors. And the metaphor for this is, think of what would happen if grocery stores controlled food stamps. And think about how they might then decide to move the food stamps to the richer neighborhoods where the grocery stores were, and then cash them in and take a profit on them. It doesn't make sense. The same practice exists with 340B. We should have the patient be the determining factor of 340B eligibility, just as the person is the determining factor for food stamps. It is help for the needy. And once we have that, now we're putting the power back in the hands of the consumer. Absolutely. If the consumer wants to go to X hospital and have treatments done that are covered under 340B, that's their choice. And so just like they have a choice about what grocery store they go to. So that would be a big step in the right direction. And I would predict that the PBMs would fight that with every ounce of strength they have, which means to me that it's a great idea.
And can I make one more point? Sorry, Terry, one more point.
No, okay.
Because I want to hear what you have to say, but this is the interesting part about this whole situation with 340B, whereas in the past, the insurers were sort of aligned with pharma because they were overpaying for these things because they were being purchased at much lower prices and charged. Because now there's this vertical integration between insurance, PBMs, and the pharmacies, the second largest provider of 340B is CVS Health, which owns CVS pharmacies. That sort of has gone out the door too. People are looking the other way on this issue from an insurance company standpoint, because as in the past, there was this separation of church and state. Now everything is like sort of put back to each other. And where the insurers were very concerned about this, that concern has gone away from people like CVS Health because they make money now on eligibility criteria with their contract pharmacy business.
And one question, so when you look at this, which I think it's a great idea, I've always thought that the benefits should follow the patient. But then if the benefit's following the patient, how does the small community health center clinic that I talked to on phone in Milwaukee, who needs, how do they benefit from the program then? Would we have a tracking mechanism for that as well, for those that really need that, the rebate? I'm calling it a rebate, it's not a rebate, but need that money to run their clinics.
So Terry, that's a great question, because if in fact that clinic is where they're saying they are, and the patient population, which I have no doubt are serving, they will benefit 100%. Because just like I said, when I trained at LA County USC, 99% of those patients would be eligible. The institution will be eligible for it automatically. So it really boils down to, if they're really serving those patients, which they are, which I have no doubt they are, they will benefit based on this criteria. What this is going to do is though remove all those institutions that are seeing one patient or two patients that make them eligible, and then they have 90% of their businesses for profit insurance, but they're taking advantage of it as an eligibility criteria to buy these drugs at a much cheaper rate and then charging everybody much higher rates. Just like you said, I think it's the idea of food stamps, right? Food stamps follow the individual, not the grocery store, so then the patient. The other thing that this gives the patient, Harry, I think people undermine, is that then they can go anywhere they want to go. Because if it follows the patient and not the institution, they can go to any institution and that the institution would benefit from it. In fact, those institutions will have an incentive to cater to those individuals to make them come to their organization, because then they get better pricing for those drugs.
And I know, with respect to Erik, I know we're out of time, but one quick story about Birmingham, Alabama, and the AIDS crisis. A lot of people left the South. A lot of gay men left the South because it was then a very anti-gay place to live, and they went to San Francisco or New York or Chicago or other large cities where they could live a life as a gay person without the same restrictions they could in their hometowns in Alabama, Mississippi, Southern Virginia, West Virginia, and all of those places. And a lot of them got AIDS. A lot of them were positive for HIV, and they developed AIDS very quickly in the 80s and the 90s. They came back to their small towns. One of the small towns a lot of gay men came back to was Birmingham, Alabama. And a clinic was started there, and it served the gay community with HIV. The gay community with HIV did not go to the expensive hospitals. They didn't go to the fancy doctors. They went to the places they could afford. And it turned out to be a community health center that is now part of the University of Alabama at Birmingham. And so why did they go there? Because they felt comfortable, because they were respected, because they could get good treatment, and they knew the people who ran the clinic. They knew their doctors. The same is true if we allow patients to control 340B. They will find those same clinics that give them superior service. And if that happens to be a major hospital system, good for that major hospital system. And if we're transparent about where those profits go and how they go back into the community, and it's very opaque now, as you both said, if we can get the clear report on where the money goes and how it's used in the community, that will make it even better.
I'm going to unfortunately have to cut us off here because we are out of time. But I want to thank everyone, our experts, for joining us today and giving us a little insight into these very important issues that are facing patients in 2023. And thank you for tuning in. To learn more about these policy issues or to get involved, please visit ghlf.org and patientsrising.org, and we'll see you next time.